All right, I'm going to make a start. Good morning, everyone, and welcome again to this hearing of the All-Party Parliamentary Group on coronavirus. On a day where the government is going to be discussing SIs relating to getting rid of self-isolation, the government has announced the end, well, not exactly the end of COVID, but certainly the end of all legal restrictions to COVID. We are now going to be, quote, living with COVID. And we have put together a panel to help us make sense and answer what I'm sure is a simple question with a not so simple answer. Is it a good idea? So in the first panel, we have friends of this group who've given us evidence in many guises, many times. It's a pleasure to have with us Professor Devi Sridhar at the University of Edinburgh. Devi is a professor of global public health at the University of Edinburgh and sits on the Scottish Government's COVID-19 advisory group. Welcome back, Devi. Lovely to see you. Thank you for coming. And we also have this morning Dr. David Nabarro, CBE. He is the special envoy for COVID-19 for the World Health Organization. So my first question to both of you, start with Devi and then move to you, David. The UK government and devolved administrations have set out their plans to, quote, live with COVID. In England, all remaining restrictions will be lifted, and including the requirement to self-isolate. In your view, is this sensible?
So I think it's a complicated answer, and that all governments across the world are trying to live with COVID-19. This virus has found its way into even the most fortress countries and those which have managed well their first waves, like Hong Kong, which is now struggling. But it's a real political decision of how much death are we willing to accept. And I think just because we don't talk about the deaths doesn't mean they're not happening. And that in the end is a political decision or decision we make as a society. Or is it 200 deaths a day? Is it 500 deaths a day? Is it 100 deaths a day? What is the cost, in a sense, of trying to prevent those? And I kind of wish that was the debate more that we'd be having rather than celebrating the end of the pandemic. The thing I would come back to is we should see now with infectious disease management, the things that they were trying to do is protections, not as restrictions. No one is talking about shutting down sectors or closing parts of the economy. What they're talking about is similar to how we deal with other public health issues. So similar to smoking, we have indoor smoking bans that limits the freedom of certain smokers indoors, but enables the freedoms of others who want to go inside and not have to breathe secondhand smoke. We have restrictions on drinking and driving. Again, it limits your freedom to drink a lot and go out onto the highways, but it enables the freedom of those who want to drive late at night safely. And similarly, the two things I wish we would maintain is the first, testing and surveillance. We know this was the major gap that we had as a country in March 2020. We probably could have avoided some of the harshest lockdown restrictions had we had that testing ready to go. So I think dismantling it is quite dangerous because how is the ability there to revamp it, and also the surveillance. That was another blind spot we had. We didn't know exactly how far seeded the virus was. So it's difficult for the modelers if they don't actually have the data to be able to input into their models. That was a blind spot. So keeping the testing and the surveillance, especially I think the free testing, we can come back to that. And second is the isolation part, which is we have now rapid free lateral flow tests that enable people to know if they are in the infectious period and know within 15 minutes. This was the stuff of dreams in 2020. If we had had this, we could have kept schools open. We could have kept sectors, employers, able to get these for their employees, to keep them in factories, keep them at work. So I don't know why we wouldn't use that to ask people to test and come out when you test negative, which is our current policy, rather than moving to a policy where you can walk into gyms, factories, nightclubs, supermarkets, and have a person next to you who's tested positive or might be infectious and therefore not having to isolate at home. So those are the two, I think, points of contention. That's around the isolation and that's around the testing more than anything else. Thank you.
And thank you. Picking up, for us in the World Health Organization, living with COVID means applying the lessons that we've learned over the years with all infectious diseases and over the last 2 years with this infectious disease to minimize the risks that are associated with this virus. And so it involves being smart. And being smart, as Professor Devi has just said, is about preventing transmission of the virus, protecting those who are most vulnerable, and preparing for new surges as and when they might appear. And in the WHO analysis, the lessons are that you don't rely on any one intervention to live with COVID and prevent it causing trouble. You combine the various interventions we have available. So preventing transmission does mean wearing masks and maintaining physical distance, especially in settings where there's a lot of virus being transmitted, partly because of long COVID still being a problem that we really don't understand fully, and partly because new varieties of the virus are coming through and are breaking past the immune protection that's available, especially when people are some months after their most recent immunization or most recent infection. Secondly, you protect the people most at risk, people with diabetes, people with cardiovascular disease, people in older age groups, and people who are heavily exposed. And thirdly, you prepare for surges, because what we've learned is this virus comes in surges. Now, the virus is the problem and people are the solution. That's the case with just about every infectious disease that I've ever worked with. There has to be a partnership amongst people and between people and authorities. If it becomes adversarial, it goes wrong. And in particular, groups of people get really upset with being told what to do if they don't feel that there is consultation and participation. Now, but if people are the solution and are being asked to take responsibility, they need to know where the virus is. And so that does mean that testing and surveillance programs are absolutely key. Any rollback of testing really is requiring us to be blindfolded as we deal with this problem. And lastly, please always remember that actually humanity is doing remarkably well in dealing with this pandemic. If we look around the world, the willingness of groups of people everywhere to take often quite difficult actions in order to protect their fellow citizens is huge. It all gets wrong when there's perceived to be some kind of debate that is then becomes heavily politicized on what is the right thing to do. Of course, if people are being required to do things through the fiat of executive power, then there is bound to be political debate. So we do really ask for sort of precaution in the use of mandates and other compulsions and the emergence of more of a partnership spirit. It puts a huge onus on leaders to be consistent and clear about what they're asking people to do. There are some leaders in the nations of the United Kingdom who are doing remarkably well, and we would like to just all the time encourage leadership that brings people along rather than leadership that sets people against each other. Thanks.
Thank you. Philippa Whitford.
Thanks very much. If I can start also with yourself, Debbie, my question is about the removal of free testing, both the lateral flow devices that obviously people have been using, care staff, visitors to care homes, etc., and indeed most of us, and separately to that, the removal of free access to PCR testing other than for the immunosuppressed. So to me, it seems very odd that we would suddenly have that if someone's symptomatic, they have to pay. We don't pay for any other NHS test for symptom. And so what do you think the impact, because both of them are different, we use them differently. So just the impact of controlling the virus, knowing where it is, knowing what variants there are, but also on health inequalities in that there will be people who simply couldn't possibly afford a test. So if I can have your comment on that and how you think it might contribute to new variants emerging if we've got high transmission and us not knowing about them. So quite separately on PCR and lateral flow, please.
Yeah, incredibly important question. I think you're right. They're serve different purposes, right? PCR testing is important to do the sequencing, to know actually, are we seeing, that's how we knew that Alpha was emerging, then we knew about Delta, then we knew about Omicron, then we knew, we can track this. And it is important to tie that into what is happening in hospitals and the contribution that is making to hospitalization rates. If we want to understand the translation of cases to hospitalizations, we need to know how many cases there are. If we don't know how many cases there are, we don't have a denominator. And I think lateral flow tests have been, I think, where the UK has been ahead of other countries, if I think of the United States, because people have changed their behavior based on their results. They have not gone into workplaces. They have not gone to social gatherings. So in a way, when I look at some of the modeling that was done, the reason I think we didn't see some of the worst case or even kind of, the projections about how many cases we could possibly have, I think is because people changed their behavior. And they were able to do that because they had the information in their hand that they were infectious. And I think most people, unless they have a financial or a practical reason, will not go out and infect others. It's usually some kind of imperative. So this will have, I think, a massive impact in terms of transmission, losing sight of where the virus is, what the numbers are, and also understanding the case, the translation of cases to hospitalizations. But the inequality issue, as you mentioned, is massive because the cost of tests are going to be too high, whether they're £6, whether they're £2. We know now that the cost of living has gone up in the UK. People are struggling just to pay heating and food bills. So I don't think getting a COVID test is going to be up there among their priorities. And that is going to be passed on, I think, to, as we've already seen, deaths being concentrated and transmission being concentrated in the poor, and also private sector and businesses having to figure out how they source these tests and pay for them. I just want to end on a final point, which is the reason this has come up is because of the costs of tests. And I think it was, reported, what is it, 2 billion a month being spent on tests in the UK. And for me, the question is not, do we pay for the tests or something else? Is why are they costing so much? Because when I look at other countries, that's not how much they're paying for the tests. So we're actually doing something, I think, wrong in sourcing these tests and figuring out why they're costing what they are, because they shouldn't be costing that much. Otherwise, I think we are having our own oligarchy happening here as well in terms of who's getting rich off the system. Thank you.
Well, I'm sure you've heard all the controversy about contracts, so we'll maybe not go into that too much. If I can come to you then, David, on the same issue, the kind of losing lateral flows, but also PCRs. Even the use of lateral flows during Omicron, which was understandable because the PCR system was overwhelmed, we lost access to positivity because we didn't have a denominator anymore. So, what's your view about the loss of information, but also the impact on health inequalities?
I actually agree with everything Debbie has said. And my colleagues who are leading the technical part of the response in WHO, particularly Dr. Maria Van Kerkhove, has recently been very explicit. Testing is key to know what's happening with this virus. PCR tests reflect the gold standard. Any pullback in access to PCR testing will limit the available data. For countries where individuals are being asked to make decisions in order to try to reduce the risks that they and others face, access to lateral flow tests is key, and they are terribly helpful. I can't make any comment on what the financial basis is for ending access to free tests because I don't know what the choices facing the Treasury are. But like Debbie, I am perplexed by this figure of £2 billion, I think it is a month, being spent on tests. And I would really want a careful economic analysis of what the risks are and what the costs of continued access to these free tests might be. So I'm not able to go further because of lack of knowledge and also my inability really to comment on deep policy issues and decisions of governments. But I would suggest a review quickly to really understand what the basis of the argument is.
Thank you very much to both of you.
Thank you very much. Before I go to Lord Strasburger, can I just ask a quick follow-up on that? So clearly surveillance is key. We need PCRs to do the surveillance. The government say that they never sequenced all the PCRs anyway. There was only ever a small number that was done. And they now say that they are intending to keep surveillance in place, although I'm a little unclear as to exactly how they're planning to do that. Is there a sort of best practice surveillance system that they can institute? What should we be recommending to government to do? I mean, they're not going to keep all PCR tests. I think that's now clear. But what can we suggest to them as an alternative? Either or.
WHO is clear that you do need to have a specialized system for surveillance. With Omicron, actually we were a bit lucky. You could pick up whether somebody had Omicron rather than Delta because it gave a different image on the PCR. But this is not the habitual way of finding variants. You need to have a specialized sampling system where you take a fraction of those who've tested positive and then do sequencing to see whether or not they've got something strange with the virus. So maintain the surveillance scheme. There is a WHO global approach. All countries are welcome and indeed encouraged to follow it. And actually Britain was quite an important leader in this. I remember listening to the health secretary at the time talk about this at the beginning of last year. Secondly, you need the PCRs for your definitive diagnosis. Our figures for what's happening around the world are not very good if people are really denied access to PCR, and you need the rapid tests for personal decision-making of the kind we've heard.
Okay, that's very helpful. Thank you very much. Bill Strasberger.
Good morning to both of you. The government is still going to require travellers to the UK to complete passenger locator forms. In the absence of other restrictions, what's the purpose of that, as far as you can see, if any? David, would you like to go first?
Okay. I'm not really sure. Actually, I don't have a good answer to that. I think, when I think of how the COVID pandemic has evolved, I guess the more macro answer, we were at a point where we didn't have testing, we didn't have vaccines, we didn't have therapeutics. Doctors didn't even know what they were facing when patients were coming into hospital. And we're now at a point where we're able to have rapid testing, we're able to have vaccines and boosters available in some parts of the world. We'll come to that, I guess, the vaccine inequality issue soon. And so I don't know why when we try to open up travel, we wouldn't be using those tools and trying to kind of keep them in place. So in a sense, I'm not saying restrict travel, I'm saying smart travel and using testing, vaccination certification, and other ways to try to keep travel moving, keep the tourism sector strong, but in ways that are safer in terms of, as we'll come to, I think later on, one of the major risks is another variant coming along and us not detecting it for some time if we don't have measures in place to pick it up either for people coming in or for people here who are getting regular PCR testing.
I suppose the question I'm asking is there any point in retaining passenger locator forms if everything else has gone?
I can't think of one, but maybe David has the answer to this one.
Okay, I'll try David.
Thank you very much indeed. I can't answer that question because I'm surprised that one area is being retained when so much else is going. For us, if you're going to live with an infectious disease, you do need to put in place necessary actions that will pick up quickly if that disease is surging and if it is causing challenges for any group in society. So we would ask that all countries focus on the maintenance of the basics of infectious disease control. And that means having capacity for alert and having capacity for response. And that capacity for alert does mean being able to pick up whether people are infected and then respond with the necessary isolation plus the necessary contact tracing. And then if you've got those elements in place, then it makes sense to also be tracking people who come in, for example, through passenger locator forms. But it doesn't really make sense having the passenger locator forms if all the infectious disease control apparatus is pretty well dismantled.
Thank you very much. That's what I thought. Back to you, Leila.
Thank you very, very much. Baroness Brenton.
Thank you very much. Is the UK government doing enough, excuse me, to prevent variants emerging, particularly but not only from countries with lower vaccination rates? David, could we start with you this time, please?
Thank you. We've always maintained that when dealing with an infectious disease that's leading to a global pandemic, you need a global response. And the global response does mean countries coming together, enabling their representatives to debate and then work with others on the collective response, and all the time trying to make sure that if there are major risks globally, that they're dealt with globally. So our request to all governments, including the UK, is that they participate fully in the design and implementation of a global COVID-19 response program. We don't have that. Why Britain in particular? Because Britain is an extraordinary leader in public health. I mean, I think you all know that, but within organizations like the WHO, you feel it, and you feel it very strongly. So if Britain is taking a sort of outlier position, is not actively contributing to a collective global response, that is a factor of weakness. And so I would like to, through you, encourage UK government leaders, despite the other distractions that they face, very important ones, to actually be doing what they can to encourage and contribute to a unified COVID global response program. We're going to be living with COVID. The whole world's going to be living with COVID for some time to come, and it needs a collective response.
Thank you very much. Devi.
And not much to add to that, except that I think in Britain, there's the feeling that the pandemic is over, especially given the lifting of all restrictions. But in other parts of the world, it's still surging. And you only have to look at East Asia, where they're struggling and they were very capable in 2020 and in 2021, as well as parts of the world, India, Bangladesh, South America, where excess deaths are still high. And so I think it's just, a very tricky message, because here everyone kind of thinks it's behind them and they're forgetting about it, and COVID no longer is on the radar, where it should still be on the radar, but in the sense of how do we get all countries to the vaccination rates that we've managed to achieve in the UK? And I think, I don't know if we'll cover it today, but kind of the idea of, are we going to continue to keep buying up supply in terms of boosters and 7th and 8th vaccines? How do we balance the responsibility here, obviously, to protect people who live in Britain with the responsibility to the rest of the world to share doses, to share the technology, to help build those factories that need to be built in Africa, so that we don't have healthcare workers unvaccinated and treating COVID patients in other parts of the world, which is unfortunately still a reality.
Thank you. Leila.
Thank you very much. Caroline Lucas.
Thanks very much, Leila. Mine is potentially a very big question, so maybe just kind of bite off chunks. But essentially the question is that we keep hearing about the importance of learning to live with COVID. And I suppose my question is, have we learned? And in your view, are we prepared for future pandemics? I know you've touched on bits of that already, but if it's possible to revisit that and maybe come to Devi first.
Yeah, big question. I'll try to be really succinct. I think we have to now use this window to think ahead. And I think a lot of the focus has been focused on the 100-day project, which is from identifying a new pathogen somewhere in the world, within 100 days being able to have products, whether it's vaccines or diagnostics or therapeutics, out and into people's arms. We managed to do this with COVID. I say we, I'm taking credit for other people, but the scientific community managed to do this in 365 days. Pretty remarkable. It needs to be even shorter. So the two questions there is, one is the scientific side, which is how do you create the road that's quick in terms of regulations, in terms of actually building your plug and play platforms, that once you have a new pathogen identified, you can move quickly to actually having the scientific products that'll help you have the exit. But on the flip side, and this is the policy question, is how do you have your adequate PPE for those healthcare workers who are going to have 100 days? How are you going to ramp up your testing so you can actually find those cases and have the surveillance in place quickly? How do you build the trust in government and clear messaging so that you don't have, with the potential MERS outbreak, 3,000 people in the park protesting it's a hoax and a third of them ending up in hospital and quite ill? So for me, those are the two sides of the equation. There's the scientific one, which Wellcome Trust, Gates, I know the governments are concerned about, but the policy one is equally as important. Can we keep schools open those 100 days? What would it require in terms of our public spaces, our conference centers, our sports arenas? And so I think having that in our mind, which is, yes, scientists are going to need the 100 days to get that out there. That's going to be their challenge. The challenge for government is, what do you do in those 100 days to buy that time and make sure that infections are prevented? Because I think the real lesson for me, or in Britain, was the fatalism at the start, that we would all get COVID, so we might as well get it over with, instead of thinking there's going to be a vaccine in a year. So what do we do in this year for every infection we prevent that's perhaps a life saved? Because that's someone who could have been vaccinated and could have lived into an era of vaccines and therapeutics. And that, I think, is the lesson for future pandemics, to have our ambitions higher, that we can do this, but it's how do you buy that time in a way that doesn't destroy society and the economy and keeps your public on board, that there's an end date to this, and that's where we're trying to get to.
That's really helpful. Thank you very much. I'll come to David now, if that's okay.
Oh, well, thank you very much indeed for the question. I've got really interested in this concept of learning to live with an infectious disease. I mean, what does that really mean? Well, first of all, if you're learning, you then have to apply the lessons in your practice, in your daily lives. And sometimes people can't do that on their own. They need help. You need help with legislation, for example, on seatbelts or crash helmets. You need help with availability, such as access to condoms for HIV prevention. You need help with often quite strong education, such as women being in a position to be able perhaps to negotiate for the use of condoms during sex. These are never straightforward things. And whenever one says learning, I always say, well, who's going to help the learning to take place? Who's going to help the lessons to be applied? Well, let's look at the different groups who might be learning. Well, people who are in situations of high exposure, like working in care homes or working in security at railway stations and so on. Well, they are going to need help because often they don't have that much power to apply what they've learned. And so the state or the local authority or the employer may need to give them some additional defense and cover so that they can actually put lessons into practice. And this always comes back in public health to the role of government, particularly when government is working on behalf of the wider public, and particularly members of the public who have less power and less influence. They rely on government to help them out. So if there is government saying people have to learn to live with COVID, and then the implication is in brackets, and there's only a limited amount we're going to do to help them, close brackets, then it's super important to look at what are the actions that government is going to take to support learning and the application of lessons. Is government particularly going to support and help those people who've got high risk, such as people with immune insufficiency? Is government going to particularly help people who are in weaker positions in society? All this needs careful work. It needs to be done in a strategic way. It needs to be debated and discussed with members of the public. There need to be dialogues, because not everybody will be able to learn the lessons in the same way. Not everybody will be able to apply the lessons in the same way. And it needs, I believe, a great deal of care. Some countries are trying super hard. We work a lot with countries that are implementing quite widespread dialogue, quite widespread work with different groups in society, analysing who's most at risk, analysing what support they need, and we are advocating that as what we would perceive as the smart approach to learning to live with the virus.
Lovely. Thank you very much. Back to you, Leila.
Thank you. Lord Strasburger, before Brandis Finley.
Yes, David, just on preparedness, can you think of any ways in which we are now better prepared for the next virus than we were for COVID?
When I suppose my initial reaction is to say, when you say we are better prepared, I would ask the question, who is better prepared? And I will then answer it by saying, I actually do believe that district public health services in many Western European countries have really advanced an awful lot in the last 2 years. After all, we haven't had a major infectious disease issue like this to deal with for quite some time. And so it's been a kind of wake-up call for the public health community to re-establish the standard operating protocols that have tended to be in place for dealing with infectious diseases, but perhaps might have gone a bit rusty. So I think at the local authority level, in many countries, at the local administrative level, also in many countries in Western Europe, things are a lot better. I think that the public health professionals are probably much better prepared than they were 2 years ago as well. I think that many in society, for example, those in schools or those in businesses, those in universities and other institutions, our military barracks and so on. A huge amount of preparedness there, and I would see that as generally good. My constant interest is whether or not governments as a whole are better prepared. And I think it's fair to say that they are, certainly in terms of being aware of the issues. But I would like to put to you that I think that the general appreciation of the role of well-organized public health services for detection and response in relation to infectious diseases has not percolated sufficiently. So much of the debate about COVID in many countries has been freedom versus lockdown. Well, we don't see it like that. We see it in terms of having in place the necessary procedures and protocols to be able to deal with the emergence of infectious disease, particularly if it comes in a surge, and to respond quickly, humanely, with full involvement of the population, with minimal disturbance to economy and social life, and maximum protection of the people who are the weakest in society. That's not swinging from freedom to lockdown. That's having a very clear public health oriented path for moving forward. And perhaps that's the part that I just want to feel a little bit more confident. I don't sense the public health narrative as strong as it should be, not just in the UK, but in many other Western European countries right now.
Do you think that governments, including our own government, have cottoned on to the fact that with these viruses, you have to move fast and you have to move hard early on?
Well, that's great that you brought that up. That's why, in a way, there has to be a contract between people and society about dealing with infectious diseases, simply because the narrative is you've got to be rapid and robust. Otherwise, things can get out of control very quickly and you get a lot of virus in society. Not sure that the nature of that contract is fully established in all Western European countries. I do feel it's strong in the Nordic countries, and certainly my discussions with people right across that part of Europe have brought it out. But I think it's strong also in Italy. I've been talking a lot with Italian regional leaders as well as central government leaders. And I think there are many other countries in Europe where it's coming on, but it ought to be something that's far more widely distributed. It ought to be certainly in education. All school kids ought to know that this is a reality of how you deal with diseases that increase exponentially. And rapid and robust doesn't mean being horrible. It doesn't mean locking down completely right at the beginning, but it does mean being smart and putting into place the surveillance activities. And then if there is a spike in a particular area, being able to deal with it.
Thank you very much. Debbie, have you got anything to say on this subject? Or shall I pass back? Okay, thank you. Leila.
Thank you. Well, I mean, it's just to round us off now. And you've covered a lot of this, but it's just, I guess, the opportunity to say all the bits maybe you wanted to say and didn't quite get round to. We're moving into another phase. What's your key message to the government?
I would like to ask Debbie to go first if she wants, but if she doesn't, then I'll go.
So as you can hear, my fire alarm has gone off as I put on my headphones. So I'll answer quickly so you guys can all get this, and I'll get out of the building then quite quickly too. So the first is that there are three major unknowns. Waning immunity. We'll only know when the vaccines don't work, when people start appearing in hospital and we figure out when they were vaccinated. And so in a way, we're learning science in real time. The second is the long-term impacts on the body. I think we're only just learning what it means to have COVID infection or recurrent infections. We learned from the States that even a mild bout of COVID-19 increases your risk of heart failure and stroke. And your third is new variants. We were lucky with Omicron. I say lucky, though it's killing thousands of Americans every day still, but in the sense our vaccines work, we need to be aware that there could be something unpredictable out there. So three things: waning immunity, the long-term impacts or long COVID, and the third is new variants. Thank you.
Thank you. It's okay if you run now, Debbie. We understand. Bye. And David.
I would just rather like Debbie, don't forget about long COVID. We really do not know what the longer term impacts of infection are. And we have new information coming out all the time. For example, the higher risk of cardiac episodes in people who've had COVID from a Veterans Administration study produced recently. Also, still not a lot of clarity on the central nervous system or respiratory system or blood clotting impacts. I think that it would be very risky indeed to ignore that. And I know that it's difficult because the facts are not clear. Secondly, my point earlier on, but I'd like to say it again, people are partners in the response, and engaging with people everywhere, whether you're at a local level or at a national level, whether you're a business leader or a professional, that is vital. And to encourage consistent dialogue about this disease and what it means is absolutely the key. And that links me to my most important point, which is you have to lead in a clear and consistent way on this particular challenge, as you do with all public health crises. That doesn't mean that you have to always be perfect. It doesn't mean that you have to always support public health measures above everything else. But it does mean being humble, because the virus is new and is surprising us all the time. And it means being honest, because out of that will come the authenticity that is needed. We've lost, I believe, in the world quite a lot of opportunities because of forms of leadership around COVID that have been, in my view, a little bit dishonest. And that leads to mistrust of leaders and the loss of any notion of authenticity. In public health, once you get mistrust, you have challenges, and particularly challenges of people working together. And you don't need a lot of sophisticated behavioral science approaches to tell you that. I think all of us understand that the heart of good government and the heart of certainly good response to a public health challenge is that there is the constant earning of trust by those in leadership positions. Thanks.
Well, thank you so much, David. Thank you to Debbie. I hope she's somewhere safe. And as ever, sage words to end with. And also, we've managed to come early to time, but we've got 3 panelists on the second half who are all here. And so with permission, I think we'll move to the second panel. So thank you so much, David, as ever, for joining us.
Thank you to you all for all you do, not just on coronavirus, but as members of Parliament, one of the most important roles in modern democratic society. Bye-bye and thanks.
Thank you. Thank you so much for your kind words. Barbara Keeling.
Thanks. Well, I'll take over as chair because Leila needs to go. And let me introduce then our witnesses for the second session. And we're joined by Professor John Edmonds. John is the Professor of Infectious Disease Modelling at the London School of Hygiene and Tropical Medicine. He's a member of SAGE and the New and Emerging Respiratory Viruses Technical Advisory Group, or NERV-TAG. Professor Matt Keeling, a very welcome Matt, from the University of Warwick. Matt is a professor at the University of Warwick and a member of the Scientific Pandemic Influenza Group on Modelling, SPI-M. And Dr. Stephen Griffin, who has given witness evidence to us before, from the University of Leeds. Stephen is an Associate Professor of Viral Oncology at the University of Leeds School of Medicine and a member of Independent SAGE, and you're all very welcome indeed. So let me kick off the questioning by starting with the point about the UK government and our devolved administrations have now set out their plans to live with COVID. In England, as we know, all remaining legal restrictions will be lifted, including the requirement to self-isolate. In your view, is this a sensible approach at this stage of the pandemic? And can I start with you, Professor John Edmonds?
Well, we do have to remove these restrictions at some point. I think the question is, should we be doing it now rather than at some time later? And on that, I'd say, the ONS infection survey still suggests that there's a large number of infectious individuals, about 2 million infectious individuals in England at the moment. So people actually with COVID who are potentially infectious to others in the community. It's a huge number, 1 in 25 of us. And so there is still quite significant risk that we're still hospitalizing about 1,000 people a day. About 100 people a day are dying from COVID. So there is a lot of COVID out there. It's a significant risk. Should we be, and easing the restrictions, removing the requirement to self-isolate, well, that will have an effect, of course. It will inevitably lead to more infections than we would have otherwise had. And so inevitably will prolong this wave of infection to some extent and lead to more hospitalizations and unfortunately more deaths. It's inevitable. So I'm not sure that I would do it right now if I was in charge. If it was me, I'd maybe leave it to where it was originally intended. I think it was originally intended that these restrictions would go at the end of March. And if, because trends are downwards generally, I think that would make more sense to remove restrictions, the final restrictions later on. You've got to think, of course, all those restrictions do have costs, but this one has quite a minimal cost in that it's only really people who are currently infectious, known to be infectious, who are telling to stay at home, rather than some general restrictions, which do have, of course, very big costs on society as a whole. So it's quite a cost-effective strategy. I don't think it's necessarily the most effective strategy. It probably is effective. It probably reduces cases somewhat, but it's quite cost-effective in that you're only targeting those people who you actually know are currently infectious to others.
Thank you. And can we come to you, Professor Matt Keeling?
Hi. Yeah, so I agree with a lot of what John said, but just to sort of reiterate a few points, we are in a situation now where hospitalizations and hospital admissions are going down, but they're only going down slowly. So the drop is, 80 to 90, well, it's dropping by sort of 10 to 20% every week. So we're on a very, very slow decline. And so anything that upsets that balance can put us into a situation where it's going to take much, much longer to be in a situation where cases and effects, serious illness, are down to a level that's much more manageable. So I do have concerns that at the moment we could just be pushing things in the wrong direction when ideally we'd like to see them get to lower values. And this could in effect be a false economy, because we know that hospital admissions have a cost. And so it's not clear to me, it would be interesting to see the sort of the economic evidence that tries to balance these two against each other. As John said, the costs at the moment aren't large. Lateral flow tests are relatively cheap in a lot of European countries that have sort of been selling them. So it shouldn't be a large cost to keep that going, but we're losing a monitoring system there. And I'm also concerned that some of the restrictions about self-isolation are really going to hit the more sort of impoverished sectors of the community that can't afford to decide to isolate. And, those on sort of 0 hours contracts who are going to have to go into work, sort of irrespective of their situation. So I do worry that this could be too early. And it's not clear to me sort of how the exact decision has sort of come about. Thank you.
Could I ask, as you're a member of SPI-EM, has there been modelling on when would have been a good time to do it?
No, we haven't been asked to do any of that.
No.
I mean, it's a complicated question. I mean, one of the issues is we know at the moment we're not back to pre-pandemic mixing. So people aren't going out and acting like they were 2 years ago or 2 and a bit years ago. And we think that's had a big change. So we know people are wearing masks, people are being more cautious, people are still doing lateral flow tests. So there's a lot of things that are going on. And we know that's not going to change overnight, but we don't know how long that's going to take to change. So it's very difficult to do an absolute mathematical prediction. I could tell you what happened if everyone went back to normal, but I can't tell you how quick that's going to happen, unfortunately.
Okay, thanks. And Dr. Stephen Griffin.
Well, I very much agree with much of what John and Matt have said. I think in terms of timing, I'd rather look at data rather than dates, to coin a phrase. And I do think that the major issue here is prevalence, because the prevalence still, even with a weakened link between infections and hospitalizations and death, as John mentioned, we are still seeing those significant challenges in hospitals. We are still seeing significant burden of long COVID. We are seeing disproportionate effects on people that are less well off. And now we're also thinking of removing some of the safeguards which prevent infections being passed on. Those people that are likely to be going out into public-facing jobs are more likely to catch the virus and therefore more likely to spread it if they're not isolating. And I really think that blinding ourselves by removing testing and removing the safeguards of not isolating is going to be a mistake. And I think that the prevalence is also going to be a problem in terms of vaccines waning, and literally we are nowhere near in control of this epidemic at the moment. We are on a downward trend, but we are seeing plateaus in many readings. And I think that keeping the ONS survey going is going to be absolutely critical if we are to see this through for the rest of the year.
Okay, thank you. Let me go over now to Lord Strasburger for the next question.
Good afternoon. 8 out of 10 NHS leaders want to see a continuation of free testing, and 9 out of 10 want to see it for care staff. Are we making a mistake in stopping free testing? Perhaps Stephen, you'd like to go first.
Yes, absolutely, because I think that compliance with testing in terms of modulating our behaviour is going to depend on the accessibility of those tests. And if we remove the free testing, and we've heard before from Devi and David about the costs of these tests, which seems strange, but making those freely accessible is incredibly empowering. But I do believe that it should also be in combination with the PCR-based surveillance systems that we need to spot variants as well, because by the time people start ending up in hospital, it's too late to catch up with cases again. So particularly in those occupations where you have more vulnerable and more susceptible people in healthcare and in care homes, for example, we desperately need to be able to monitor the infectiousness of people. And it's about the infectiousness. And the other point I would make is about vulnerable people. And I'd say that about both clinically and societally vulnerable people as well. You need to not necessarily know if you are infected, you need to know if other people are infectious. And I think that's a major constraint on the behavior of many people who are going to essentially be asked to go back into shielding and to live a sort of half-life again, as many other people carry on, pretty much, as Devi said this just earlier, forgetting that the pandemic's actually in existence still. We need that reminder. We cannot just move on and ignore this. If we want to live with it, we can't ignore it.
Thank you. Matt, would you like to go?
Yeah, sorry, I was struggling with my mute button. Yeah, so I agree. I think I would love to see free testing carrying on for longer. I think it would be incredibly helpful. Whether or not we need to do quite as much PCR testing, so it's PCR testing that is really expensive. That's the thing that sort of drives the cost up, whereas the lateral flows are relatively cheap. And I mean, what we saw sort of just before Christmas, we've got Omicron coming, we were all worried about it. And, there was a fantastic public health message that went out that, before you went to see anyone that was vulnerable, you tested. And it looks like the country did this. We are very good at responding to simple, clear messages, but we can only do that if the tests are freely available. There's going to be a large number of people who won't afford tests. We are in an economic squeeze at the moment, so that's putting a lot of pressure on people. And, we talk about changes in behavior, but it's risky behavior that we're interested in. The whole problem is infected people meeting susceptibles. Any other sort of mixing isn't a problem. And so if you can find out when people are infected, and the only way you can do that is testing, then you can mitigate some of the worst effects. So, I know there's been talk of sort of having free testing for NHS staff and maybe for vulnerable people. And possibly we can get that to work, that vulnerable individuals can give the test to those that are going to meet them. But that's where we need to be breaking that chain, is stopping allowing people to find out whether or not they're infected, and therefore sort of knowing that they can minimize their risk. So you're giving people the information to be able to act responsibly. And I think that's got to be the key message in all of this.
Can I just clarify, are you saying you'd be satisfied if lateral flow testing continued, or do you want PCR testing as well to be free?
I mean, PCR testing is great because it gives you lots of information. So it can tell you about new variants coming in. So it's very, very useful in that respect, but it is also very, very expensive. So I think, it might be that a halfway house is that we keep lateral flow tests, which are cheap, quick, easy, and give people, an immediate reaction. If I'm feeling unwell and I can do a lateral flow test and find out, then I know I can change my behavior. Whereas if it's a PCR test and I'm waiting 3 or 4 days and it's also much more expensive to do, then it just puts extra delays in the system. So, I mean, with the science hat on, I'd love PCR testing to continue because I think it gives us a lot of valuable information. But I can see that you could get away with doing lateral flow tests for an awful lot of these situations and just do PCR. If you start seeing a large number of cases in a region, suddenly maybe you could go in and do PCR then to find out. So targeted PCR testing, which would be a lot cheaper, I think might be an alternative.
Thank you very much. And John, what would you like to add?
Sorry, I was trying to find my mute. I think what you have to distinguish is between symptomatic testing, so those people with symptoms, and asymptomatic testing, so those without. And what is the point of testing? Why are you doing it? So people going into hospital, you're going to want to test because it determines what you're going to do with those patients, how you're going to treat them. So are they going to go through some sort of COVID pathway and be treated with antivirals for COVID and so on? Or have they got something else, and would they go through like influenza and go through another pathway? And these other viruses are going to come up now. As we lift general restrictions and we start to get back to normal, we will get other viruses in the community. So it's essential in hospitals to be able to know what it is that you're dealing with. What is it? What has this patient got? So that's not going to go away. That will still cost a lot of money, and that will be primarily done by PCR. Do you have to test people in the community with PCR, for instance? Well, perhaps not. So there may be a surveillance issue. So you might want to do that on a sentinel basis for some people, and that's where the ONS survey comes in. That's the best way to do it. It's a community random selection of individuals, and you test them in the community to see whether they've got COVID or not. So certainly I think all of us would like to see that to continue. So there's a surveillance reason for doing testing, but then what are the other reasons for doing it? So how's it going to change people's management if you test them with a PCR or test them with a lateral flow? Well, at the moment, we're not asking them to do very much because we're not even asking them to stay at home if they're symptomatic. So there's really not that much point in testing them. Now, so, one follows from the other, if you like. I as I argued before, I'm not sure I would stop people from staying at home at the moment. But if you've taken that decision, then there's not much point in testing them. Then you have testing of asymptomatic individuals. So this is the sort of flow before you go that Matt was talking about, which was, I think, highly successful before Christmas at slowing Omicron getting from where it was initially spreading, which was the young adult population, into the older, more vulnerable populations. It was highly effective, actually. You can see how Omicron moved slowly between the age groups, and that was almost certainly because people were testing themselves quite assiduously before Christmas in order to as increases in contacts across age groups occur around the Christmas period, and people tested themselves to prevent infections from occurring. And I think that was very effective. So do we want to get rid of asymptomatic testing? Well, I can see the reason for it from the economics point of view. But where I think what we need to do now is do a hard-nosed cost-effectiveness analysis of this. So where is that? Is that in the the assessment from the government? It's certainly not published. I've never seen anything. So have they done that? So what would be the effect of removing or asking people to pay for lateral flow tests for asymptomatic testing? What effect might that have on the transmission of the virus in the community, and how costly? Because of course, as Matt said, if you're preventing people going to hospital, there's a benefit there, and there's a cost that you haven't paid. Now, I think that all of those analyses ought to be done now. They ought to have been done before the decision was made. But given that we are living with COVID, I think we could do those sorts of analyses now. I think those are the sorts of things that we ought to do. Take our usual kind of cost effectiveness thresholds that we normally use for other endemic diseases and go through the process. I also think that we could design randomized controlled trials to see the effect. If I move it on from asymptomatic testing in the general community, you could think about, we're also getting rid of asymptomatic testing in care home workers and those who are at high risk. At the moment, the Living with COVID strategy says that we will continue to offer symptomatic testing for those in high risk groups and care home workers. So if they've got symptoms, then they can still be tested. But I think there's a strong argument, maybe we could do a trial to look at the effectiveness and cost effectiveness of, say, asymptomatic testing in, say, care home workers. Does that prevent infection getting into care homes, and at what cost? And maybe, I would suggest it's probably likely to be the case, there may be some threshold prevalences, so as the prevalence gets high, it may well be worth testing care home workers to prevent them bringing infection into care homes. And that sort of thing, those sorts of studies could be done. And I think strongly that we should be doing those sorts of studies now. There should be, that's what living with COVID and how best to go about it should be done. There's almost nothing in that strategy document along these lines. It doesn't really say what we're going to do with living with COVID. It really just gives a list of what we're not going to do anymore. But there are many things that we could do to prevent, to manage this infection going into the future. And I think we should be setting up those studies urgently and doing them now.
Sounds like you're advocating being led by the science, which seems to have gone out of fashion this year.
Not just the science, but also we do have general norms that we use from an economic analysis point of view. There's, that we use for all other diseases. NICE uses them, for instance, to decide whether a drug should go on to the be funded by the NHS. And these are things like cost per QALY or life year gained and so on. These sort of norms that they use. We can apply those to these sorts of questions, and I think we should start. That would be then putting COVID on the same basis as every other disease that we deal with, whether they're infectious or not. And that, I think, is the way to go about doing this. And if you don't like those norms, and I think we should have a discussion, about how much we should pay for a life year saved and things like, that's always been brushed under the carpet for decades, and certainly was during the COVID outbreak. But now people are a little bit more aware of this, that there must be some cost that is unacceptable, and you wouldn't just pay anything to prevent a life lost. So I think we do need that debate in public to come to look at those norms that we have been using for years. Are they appropriate? Maybe that would mean that we might need to spend more on our health service, for instance. But I think all of this should be done now as a matter of some urgency, and put it on the same footing as everything else, and make some sensible decisions about how we actually live with COVID. It's not really written down in that document.
Thank you very much. That's given us plenty to think about there. It's very helpful. Back to you, Barbara.
Thank you. And can I come to Caroline Lucas now? Caroline.
Thanks. Thanks very much, Barbara. There were two quick things. I wanted to follow up on the point that was made that the crunch point comes really when you've got infected people meeting susceptible people. And I suppose The difficulty with that is that lots of us don't know who is susceptible. You don't know if the person in the carriage next to you or the person on the seat next to you in the train carriage is susceptible. So presumably that is still an argument for mask wearing, which I just want to ask you that. But my substantive question was actually, if I could come to John first, was picking up on the point that you put in the chat about the cost of these lateral flow tests, because you'll know that the figure of 2 billion has been put out there per month. And you'll have heard Devi and others saying, you know, we need to ask ourselves why it's costing so much. Is it value for money? I note in the chat you were saying that that actually that 2 billion a month is the entire cost of the test and trace program, and that the LFDs out of that would be a small fraction. Do we have a sense of how much that would be? If I can come to John first.
I don't know. It's not that difficult to calculate. I was trying to look it up just now. But it should be quite easy to calculate. I think the lateral flows cost about £3 each, I think, which, to put into context, the PCR costs £30 to £40 each. And if you back in at the beginning of January with the Omicron wave, we were testing over 600,000 people a day with PCR tests. That's an enormous number of people. That's so I think that comes out to be about sort of £20 million a day being tested, being spent on just PCR tests. So that's that's where you can quite rapidly get up to sort of billions of pounds being spent just on PCR tests, and that's not including those that then would go on to be sequenced, whole genome sequencing, which costs, I don't know exactly how much, but about £100. Between 60 and £100. And a good fraction, usually about, I don't know exactly then, but about 10% were being sequenced. So you can see the costs quickly rack up enormously. Whereas with lateral flows at £2 to £3 of test, it's much, much cheaper. I don't know exactly how many were used over that period. That's not easily available on the government website. The problem is that what people report, many people don't report their negatives. They just report, many people just report if they're positive and don't report their negative results. And so it's hard to know. But the government will know how many they're supplying out, so they could easily work out the cost. But it would be not an insignificant fraction, but it would be just a fraction of that £2 billion a month that was spent in January.
Thanks very much. Not sure if Stephen or Matt wanted to add anything to that.
No, I'd agree completely with what John's just said.
Okay.
I think certainly picking up on your point, Caroline, about masks and things, I think that one important thing that's often overlooked is that the responsibilities for not spreading infection is all about altruism. So having your vaccine is about altruistic behavior. Wearing a mask is altruistic behavior. Testing before you go somewhere is altruistic behavior. And I think that there's a danger with the idea that this is all now behind us and that all the restrictions have gone and we don't have to do anything, as John rightly said, as a result of a positive test. That responsibility, that altruism may start to diminish. And again, I think this has a disproportionate effect on people who are clinically vulnerable and people who are more likely to encounter the disease. And I think this is something, as well as long COVID, that we really need to start thinking about more, because I personally am not comfortable moving ahead with everything and knowing that a significant proportion of the country are being left behind. So I would emphasize that we should still have the abilities and the accessibility to these tests. I would still say that the guidance on masking and improving ventilation in public spaces is absolutely something we should be thinking about. But that doesn't seem to be, as John rightly said, anything in the document about that. It's more about what we're not doing. And that to me sounds more like appeasing people than helping them to do what's right.
Lovely. Thank you so much. Back to you, Debbie.
Thanks. So let me move across to Baroness Masham, who's going to ask a question about self-isolation.
Good morning. It's nice to see everybody. What will be the impact of removing the legal requirement to self-isolate? Will this not help to spread the virus? And what about collecting data? I think it's all very confusing for the public. Could we have Professor John first, please?
Okay, so yes, it will help to spread the virus. I mean, it's not designed to do that, of course, but it's inevitable that you will get more infection as a result of that. You know, there's no question about that. The issue is just how much. As Matt said, we haven't modelled it. We weren't asked to model it, so and it's not an easy question to answer. But we could potentially lend ourselves to, you know, we potentially could look at some of the models, but we haven't. We weren't asked to do it, and we haven't done it. So I'm speaking to you from a kind of mental model rather than something where we've got some quantitative results that we can look at and refer to. We don't have that situation, but. If you think about it, at the moment, as I was saying before, it's quite how effective the strategy is. It's not that clear. You know, asking people to self-isolate. Clearly, it must have some effect. You know, at limiting transmission between households in particular. You know, so it's bound to have some effect on doing that. So removing it, you might think, would therefore have quite an impact. However, I think it's likely that many people will continue to do this anyway, or particularly while testing is still freely available, which it is still at the moment. And so I think that many people, if they test themselves, they're likely to do it anyway. I don't think employers want their employees spreading COVID in their workplaces, and so I think employers mostly will take a sensible approach to this. So I suspect that many people will continue to self-isolate as best they can in the short term, and so the impact might not be enormous. As I think Matt might have mentioned it earlier. I suspect what will happen is that those people who don't have such good employers, or perhaps are self-employed, freelance, and so on, might not test themselves, might feel obliged to go to work, and so on, and their employers might demand them to come into work. And so I think what we might see is a shift in the disease, and its burden of disease in different sectors of our society. I suspect we'll see it shifting towards, prevalence increasing in sectors of the society that poorer parts of society, or those who in the gig economy and so on and so forth, perhaps younger individuals and so on. So I think we'll see a concentration of disease in certain groups, unfortunately.
Thank you very much. And now could we have Professor Matt?
Hi. Yeah, agree with what John said. I mean, our estimates are that we've got a reduction of about 50% in the amount of transmission that's going on now, compared to what we would have seen sort of, pre-COVID, when no one was taking any measures. I think the key question is just, how quickly will we return to that pre-COVID measure? I mean, what we've seen throughout is, when we had the step changes and, pubs open, that doesn't mean the first day that pubs open, they're full. People take time to react to these things. It's been a very slow process coming out of the last lockdown. We know that people generally are try and behave sensibly when they can. I mean, one of the pieces of evidence we've got that suggests this sort of 50% reduction is about right is the fact that we're still not seeing any influenza. The current set of behavior, which is really going to be mask wearing and minimizing your interactions in risky, crowded places, has been enough to stop flu, which is a phenomenal achievement, really, when we think about it. So we know that we know that we've got control at the moment, and we know that there's room for things to get much worse. I would expect that to be slow. I expect people to be sensible, and I expect these things will take time, but eventually we're going to start moving back to a situation in which R is going to creep above 1. It's probably about 0.9 at the moment. It could if everyone went back and just mixed as they used to, we could probably go almost as high as 2. So there's a lot of wiggle room in this, and it doesn't take much for things to start growing again. And I think that's my concern, is that if that does happen and tests are being phased out, we're not going to see it until these individuals start ending up in hospital. And it can be even worse, because if it's in the younger generations, we won't see it at all. We could build up quite a head of steam before it gets into those that start sort of going into hospital. So we are in the situation where we're sort of losing this early warning system. And it could be that things get pushed into more vulnerable groups, and then eventually we'll move into the sort of the elderly, and we could start then seeing it in hospitalizations, which could be a little bit too late. So yeah, I'm concerned about it, but I can't give you a quantitative answer as to how big an impact it's going to be or when that impact's going to happen.
Should there be a campaign to wear masks? Because so many people don't seem to be wearing them, certainly in my part of the woods.
Well, I'm still wearing them. My family wears them, and I think, it's just good protection. I would like to see them become, a sense of, as Stephen said, altruism. It's something we do to try and protect others. And maybe, in the winter, if you're feeling like you've got a bit of a cold, well, then you put a mask on and you make sure you don't infect others. And maybe that ought to be seen as a positive thing. That these people are actually trying to protect others in their community, and when they go shopping, when they go to work, the last thing you want to do is infect your entire workplace. So I'm all for wearing masks, but obviously it has to be, at the end of the day, I don't think we can keep it as mandatory, but I think it's one of these things that ought to be encouraged as a selfless act. And it's pretty low cost. I mean, I'm happy keeping my mask on all day. I give 2-hour lectures with a mask on. It's not a big problem.
I totally agree with you. And now it's Dr. Stephen, please.
Well, I mean, I'm not a numbers person per se, like the other two, but so I agree. There isn't an easy measure of what might happen if we stop self-isolating, but there is an interesting measure about what's happened when you stop contact isolation. And that's in schools. So there's been an exemption from isolating for under 18s for several months now. And it's fair to say that both Delta and now Omicron, the prevalence is largely centered in that age group. In primary and secondary school kids, this is still where we're seeing loads and loads of infection, loads of transmission. And that's partly because, it's difficult to stop spread amongst households. But if you're also then not contact isolating people, they will come back into school, and they will, even if they're testing every day, still have that risk of passing infection on. Now, I think that the problem with that is, as we're seeing, that prevalence remains high. And when prevalence remains high, we've already talked about long COVID. We've already talked about a disproportionate effect upon people who are clinically vulnerable. There's also the fact that when prevalence is high, these minor problems that we see in terms of the percentage risk are compounded by the fact that we have a large number of infections. So, for example, the number of children going into hospital has increased as a result of this behavior and lack of mitigations. And we start to see those less common but perhaps more unfortunate aspects of COVID happening more and more because prevalence is driven. And it's also an assumption based on a relatively static affair, in the sense that we're assuming that our vaccinations, which they probably will protect us in the longer term against more severe disease. However, we're not in a kind of in a stable equilibrium here. Many people are shouting, shooting off terms like endemic and things like that around, which is not the case. We have a dynamic state of affairs with the virus, and we have a dynamic state of affairs in respect of our immunity. And until those things are stable, and I believe that will require a world level of stability, ideally, but certainly in this country, it's still not stable, and we will continue to see people going into hospital as a result of high prevalence. So I think that anything that will push R above 1 or indeed maintain prevalence as it is, because remember, the change doesn't mean that things go down. We're around about 1 at the moment. We have high prevalence higher now than we had for most of last year. It's still there. and we will continue to see people hospitalized and hundreds of deaths every day. And I don't personally think that that is a price that we can pay, especially when, as Matt rightly says, some of the measures that we can take to reduce prevalence, combined with hopefully better weather and changes in behavior over the summer, can actually drive prevalence down and minimize those risks and minimize those disproportionate effects on people in our society that are having to take additional precautions as everybody else moves on.
Thank you very much indeed. Perhaps we can press the government again, putting down some questions. Now back to the chair. Thank you.
Thank you. Let me come to Dr. Philippa Whitford. Philippa.
Thanks very much, Barbara, and I'll start with Stephen, just for a change. Just agreeing with you, the use of this term endemic to suggest it means mild, I think is really concerning when you consider all the lethal endemic diseases that exist across the world. But following on from Susan's question, obviously when there were surveys about, you know, how many people were actually isolating as contacts, or, you know, if they thought they might be infected and getting tests and so on, particularly those, as was referred to in the gig economy or 0 hours contracts, what do you think could be done to try and support those who aren't going to be able to afford, whether it's a lateral flow test or a PCR test, no matter how they feel, they're probably not going to prioritize the cost of getting tested, and then are in that vulnerable working space where they won't be supported. The payment is now already disappeared, measly as it was. So what should we be doing? Because otherwise I do really think we are going to end up with work sectors and sectors of the community where this is just going to be raging, and they do not have the tools, the access to the tools to control it.
I completely agree, and I think there's actually already good studies on this. You know, there are professions, I think bus drivers were one, education sector, care homes, where not only are they more likely to have contracted SARS-CoV-2, they're also more likely to develop long COVID, and so there's a longer term impact there as well. I have for a long time believed that the support for isolating and statutory sick pay is woefully inadequate, especially if you compare that with other countries in Europe. So I think it's absolutely right. It's difficult to ask people to isolate and take time off work if you're not then going to support them to do that right thing, that altruistic thing. I think, you know, I mean, personally speaking, I was able to work from home most of the time, still am most of the time. I had personal circumstances that made that absolutely necessary, but many people couldn't do that. And for many people, you know, and clinical colleagues as well, they didn't really experience lockdowns in the same way that many of us did, because they were having to go out and do deliveries or work on the wards and things like that. So until that's recognized, and I think, you know, I think it was mentioned before about what we do in terms of preparing for the next pandemic, recognizing that provision to support people to do the right thing will actually have a longer term and wider cost benefit, because you're preventing infections. That prevents people going in hospital, and that really is what costs a lot of money. Putting someone into intensive care, you know, if we're going to talk about costs, that really is tremendously expensive. So let's apply a bit of prevention is better than cure. It really is that simple. That's fundamental public health. That's why we need to maintain testing. That's why we need to maintain basic public health precautions, such as isolating if you're infected.
Yeah, the S bit of TTIS was kind of constantly ignored, as in test, trace, isolate, support. I mean,
Yeah,
it took so long to get the £500,
yeah,
and it doesn't even meet minimum wage.
Mm-hmm.
So that would be your thing, obviously, access to free testing for people to know that they're positive, and better financial support.
Yeah,
what
but
about
it all
yourself?
depends on prevalence as well. Sorry, it does depend on prevalence as well. So, you know, testing when there's very, very low prevalence, I think everyone would agree is just, it doesn't work very well. Doing hundreds of thousands of tests when there's no prevalence. But at the moment, we haven't had that. We haven't had that since July. So let's be realistic. We either get prevalence down, or we need to continue testing. And on the point about endemicity, yes, endemicity means predictable, and it can be predictably high and bad, or it can be predictably low and still bad. But let's try and get it low.
Okay, thank you. Professor Keeling?
Yeah, I would agree with everything that's been said. I mean, what we can do to support these people is not in our remit. We deal with the public health, we deal with the epidemiology. We're really talking about an economic and a political question there. But I think it goes back to what John says. We are very, very used to thinking in terms of health economics. How do we weigh up a treatment, a drug, a vaccine against some sort of benefit that you would see in terms of individuals, in terms of costs in hospitals, this sort of thing. We could apply exactly that sort of regime and reasoning to all these questions to do with COVID. It would need joining up between the epidemiology and the economics. So it would need some sort of agreement between the people who do what we do for the epidemiology and those that do it for the Treasury. But there's no reason why those models can't be combined, and we can't look at what would be a worthwhile strategy. So from a personal point of view, I would love to see people more supported and the ability to take time off when they're ill. But could we actually look at the benefit to society as a whole? Would that £500 be actually be a net benefit? Because it could be that you're paying these individuals, but it's great because you don't then have the knock-on effects of hospitalizations and other people being ill. But it's very difficult to know without the detailed economics to back it up. And that's outside my field.
I mean, the other thing that we look at, my background is as a breast cancer surgeon, obviously all the agonizing for any testing or screening program on whether it narrows health inequalities or widens them. And to me, it just seems as if this decision to remove not just LFTs, but also PCR testing for symptomatic people, it hasn't been looked. And as I said in the first session, we don't charge people for other symptomatic tests in the NHS. So it looks as if on both cases, there hasn't been that normal cost benefit kind of analysis and health inequality analysis. If I can come to yourself, Professor Edmonds.
Yeah, nothing to add. I mean, I agree entirely. I do think we could do these analyses. I do think they're difficult. They're not as straightforward as, say, testing for breast cancer, which in itself is difficult enough. Because with an infectious disease, you also have to look at the knock-on effect that it has on others in the community if you test them and ask them to self-isolate. So it does need complicated epidemiological models to be linked in with the economic side of it, but it is doable. Matt and I do this sort of work for the JCVI, for other things, vaccine-related diseases, for instance. It is all doable, and I think we should probably be looking at this with some, but we need a program of work to look at it over the next few months or even years, to come up with a sensible strategy about how we cope, how we live with COVID.
And also future pandemics. I mean, because would this not help arm, obviously, politicians like us, who very much feel we should be looking at the public health, but also to convince governments that, well, we've done the sums, so, don't moan about that. This is what we need to do to get the best outcome. So I just wonder whether having that information would help the debate, which has often been a bit blind here.
Yeah, well, of course it would.
It allows you to quantify something that otherwise just becomes, very emotive about whether or not what are you trying to minimize? I think that could be a question that's out there. Are we just interested in minimizing some sort of health economic loss, or are we worried about long-term potential? There's a lot of complicated questions that come in. So it's not just a simple sum. There's also a sort of a risk mitigation problem. Do you take the risk that 5% of the time you could have a complete disaster? Well, our strategy so far has been, certainly in the early waves, we tried to avoid that. But the questions about how you deal with risky situations and large amounts of unknowns, I think, is very, very complicated. So, do we put strategies in place now that buffer us against future variants? Well, that's a complicated question, and that's beyond science. That needs more sort of politics and community involvement.
But we have tended to oscillate between public health panic and economics. Stephen, you were trying to get in just
Philippa, I think we need to
before we finish.
We're running out of time. Yes, thank you.
Oh, sorry. Should I?
No,
Oh, okay. Just very quickly then, just two caveats. I mean, I have a limited understanding of the sort of health economics of things, but there is an issue around chronic disabilities and the way that quality adjusted life years are calculated and things like that. And the other thing that it does also sometimes curtail, and I'm sure it's more sophisticated than my understanding of it, is that the value of rare diseases can be overlooked because of the net benefit to society. But actually, if you add lots of rare diseases together, that does give you a benefit. So that's just the only thing I wanted to add.
Okay, thanks very much. Back to you, Barbara.
Thank you. And let me come to Debbie to ask our last question, because we are down to the last 3 or 4 minutes now.
A very quick one. Although I see Baroness Brinton's also looking for she wanted.
What I was doing the next one, 4A.
Philippa asked that question.
We've just done 4A.
Right. Can I have a supplementary then, please? Because I did actually mark down that I wanted to ask one very specifically on the guidance for the clinically extremely vulnerable.
Okay, that's fine.
Right. So in September, when shielding was abolished, the government said the clinically extremely vulnerable had to risk assess what they were doing. How can they do that if there is no data, no surveillance, no free tests, and they don't know who and hasn't been vaccinated? What would your advice be to the clinically extremely vulnerable?
Shall I take that? At the moment, I would tell them to stockpile lateral flow tests while they're available, and when people come to see them, family members or people coming to work in their houses or whatever it might be, that they ask them to take a lateral flow test, because indoor contact is the most risky. In your own home, particularly people who are spending some considerable time with you in your own home, is the riskiest sort of thing. And so I think that I personally would like to see them have free access to lateral flow tests, but if we are not going to allow that, then, and not for their own use, for visitors, for people coming into their own home. But if that's not going to happen, then I would tell them right now to stockpile them as much as they can and do that themselves. As I say, this is one of the things where I think we could evaluate this, allowing the clinically extremely vulnerable to have lateral flows, or indeed, as I mentioned it before, those in care homes or workers in care homes to be continuing to test on an asymptomatic testing basis, not just symptomatic testing, which is what is it in the strategy, but asymptomatic testing for care home workers, perhaps when prevalence is high. So, at what prevalence does it become cost effective for asymptomatic testing to occur? So it could be when prevalence is high, you allow the clinically vulnerable to get lateral flow tests from their chemist or whatever for free on prescription, so that they can test people coming into their home. And that might be every winter or whenever it is, whenever prevalence gets high. At the moment, prevalence is very high, and I would suggest that they would continue to use them to protect themselves.
Thank you. Stephen.
Well, I would suggest that shielding never really stopped, whether or not the government decided it did or didn't, for many people. I think that the issue with clinically vulnerable people is similar to the criticisms that were made of things like the Great Barrington Declaration, is that it's very hard to identify people who are clinically vulnerable, and that's extremely and/or just vulnerable, and I wouldn't want to be in either of those. The irony being that those people are sometimes less likely to be as well protected by the vaccine. Also, there's a huge number. We're identifying more and more people that are susceptible to severe and/or longer-term effects of COVID all the time, and identifying people that will become vulnerable. We're all one doctor's trip away from being clinically vulnerable. So my view is that rather than making special dispensation for those people, is that we should try to achieve a state of being where the risks to them, as John rightly said, when prevalence is low, where the risk is diminished. And I believe that we have the tools in our arsenal to do this. And frankly, it's quite maddening that we're not doing this, because we're talking about millions of people here. And I think that the policy needs to be revised in that aspect.
Okay, thank you.
Thank you. Matt, do you want to add to that? Or
no, in the interest of time, not really.
No. Okay, because we have run out of time now. Debbie, if you'll just ask our question to wind us up.
Yes, very, very briefly. In a sentence, could you each give your key message to the government as we enter this new phase?
Shall I go? I think we need a proper plan to deal with surges of infection, probably related to new variants. That isn't there at the moment. So it's not in the strategy. Apart from it, just says we'll have a reliance on pharmaceutical measures, which is antivirals and vaccines. But we need to be careful with that. If we're going to be surging vaccine use and as we did with Omicron, then we'll have to know how and when to respond. When do we respond? When is it enough that we should trigger that? And the problem is that because we're dismantling our surveillance system, not entirely, but we are. It will be less sensitive. That it will take us longer to know if we have a problem. And so I think that is a really fundamental problem that needs to be addressed properly in a plan. So we need. And that simply isn't there in the Living with COVID strategy. So how will we actually cope with new variants?
Yeah, very, very good point. Stephen?
I'd say two things. One, don't blind us. We need to focus on prevalence. Prevalence challenges those less able in society. Prevalence challenges waning vaccines. Prevalence means that minor percentages of things going wrong happen more often. And so real-term values are still a major issue. And also long COVID is something that we absolutely need to think about. And again, that's linked to prevalence. At the end of the day, the problems we face are to do with the level of massive infections that we are seeing. And so we have a fantastic vaccination rate in certain age groups. We need to focus on getting that across the board and make sure that our children are protected as well.
Thank you. And Matt?
Yeah, I mean, I agree with what's been said. I'd echo some of the things and stress that, the future is still very, very uncertain. We do not know that we're going to hit, what everyone's calling endemicity, and they think this is going to be very, very low levels. Well, I'm afraid that could be 5 to 10 years away before we hit that. We're likely to have a very bumpy road ahead. And I think what we need is a plan that really tells us how we're going to deal with these bumps. So it could be variants, it can be waning immunity, it could be changes in behavior, it could be what happens next winter. There's a range of things that could start triggering problems. And as has been said, we're going to be blinded by lack of data, and we need some way to know when we start stepping up so that people can plan properly. And I think that stepping up is what I'm not seeing in any of the documentation.
Very helpful. Thank you so much. Back to you, Barbara.
Thank you. Just to close the session, and thank you for sticking with us as we've run over time a bit. I really would like to thank all our witnesses for your time today. It's been incredibly valuable, and I think, to us as politicians, it helps arm us with the questions that we need to be asking. And that's really very valuable today. And I was sitting here making notes and thinking, which questions can I put in, which points can I make, and I've really drawn on everything you said. So, and I'm sure all my colleagues are in the same position. So thank you very much indeed. Thanks for your time. And I close the meeting there. Thank you.
Thank you very much.
Thank you for inviting us.
Bye.
Bye.